I'm Wendy Chung. I'm a medical geneticist and pediatrician and very happy to be here for the DYRK1A conference where I can tell you about what's been going on at Simons Searchlight and show you your data. What is Simons Searchlight? Well, believe it or not, about 10 years ago, we decided that it would be good to support the rare disease community of conditions related to neurodevelopmental conditions. Some individuals in those communities have autism, but not everyone does. And I know it can feel very much isolating not to have lots of other people in your neighborhood or in your town who have the same condition. So we wanted to be able to bring people together virtually from around the world to share experiences, to learn together, and hopefully develop what we think of as clinical guidelines and best practices, or ways of being able to take care of our children and family members with these conditions. I'm proud to say that DYRK1A is one of those conditions. There are over 150 of them total, but they share many similar features. As we're doing this, as I said, these are not restricted either by age or by country. Everyone from around the world is invited. And as we do this, we wanted to make it easier for researchers, wherever they might be able to work for you. So as we're doing that, we de-identify all of your information. In other words, no one knows who you are, but you're able to provide your information once, and as a multiplier, allow Simons Searchlight to then share that with researchers around the world, whether they're at universities, medical centers, companies that are trying to develop treatments, wherever they might be, so that everyone can pitch in and do their part. And you only have to do that once. You don't have to do the same thing over and over again. As I said, with doing this, it's mostly information that you've provided either by talking with one of the genetic counselors or by filling out a questionnaire online. But as I'll show you in a second, some of you have actually contributed a part of yourselves, literally a blood sample, to be able to help those researchers do their jobs better. So I'm going to tell you today about the information from the DYRK1A portion of Simons Searchlight. In terms of the size of the community, it's getting bigger, and that's fantastic in terms of making sure that the information we have is factually correct and representative of the community. But I will say it is one of the limitations, and I'll show you exactly what I mean by that in a second. For those of you who either haven't registered or think you maybe did part of it, but maybe not everything that you hear me talk about today, just to let you know, you can always hop back on and complete your registration process, complete questionnaires, or talk with the genetic counselors in step 3, actually being able to talk with someone who knows about your condition and who may be able to help you understand better what you're experiencing and where that fits in with the DYRK1A community. Within this is not one and done. It is meant to be an ongoing understanding over the life course of what it's like for individuals with DYRK1A. So in doing this, we come back to people to see year after year, and I'll show you some of those data, but year after year, how things may be the same, how they might differ. In particular, we're looking to understand for each other, for those people who might be a little bit older, what does that inform us in terms of the individuals who are a little bit younger? So in doing this, like I said, we're in it for the long haul. We're not going away anywhere. To be clear, we're not selling your data. We don't make a profit off of any of this. All of this is financially supported by the Simons Foundation and is free of charge to the communities and the community members who are part of it. As I was saying, some of you have provided actual samples, mostly blood samples, in terms of researchers being able to work for you and help you out. I'll show you in a second, but it is important to me that everyone's represented because everyone in the DYRK1A community is a little bit different either by how old you are, where you live, even some of the different genetic variants in DYRK1A are different, and there may be some differences between those. One of the things that researchers can do with your blood samples is use those to make what we call induced pluripotential stem cells, or iPSCs for short. Right now, this isn't something that we have yet for the DYRK1A community, but for any of you who are researchers out there, and I hope at some point there will be, we're interested to hear from you if this is something that you could use in your research. Again, we've been doing this for many, many different conditions, making this live library of iPSCs available, and it's something that's very expensive. So we're doing it for the family groups to be able to make it easier for talented researchers around the world to be able to study the condition. So we're creating, I think of it as a toolbox of different tools that researchers can use to work for you. Again, if you put your sample in, no one knows who you are, but it does ensure that you're represented. So if researchers are working on a treatment, a cure for the condition, it makes sure that you're represented by having a little piece of you in there. These induced pluripotential stem cells are this word pluripotent means it can be made into many different types of cells. And so this is incredibly useful to make some of these cells into brain cells. Those brain cells can be used as models to see whether or not these new treatments, in fact, are effective. And again, can be used to make even what we call mini brains. And believe it or not, they really do look like they're little tiny, but look like little collections of brain cells that can even give us some of the three-dimensional organization of what a brain is like. Of course, it's nothing really like the complexity of a human brain, but it is something good to be able to test before we get to the point of testing it in people. We want to test for safety and efficacy before we ever expose a person to any of these new treatments. So this is, again, mostly for the research community, but I did want to share back everything we have with the families. This is a summary of the different genetic variants in DYRK1A in the individuals who are part of Simons Searchlight. This is based, for those of you who were part of this, you may remember that you sent in a copy or uploaded a copy of your genetic test report. We do that as a method of now abstracting from that the exact genetic change that you have and making sure that it really is in DYRK1A, that it's the what we would call a disease-associated or condition-associated genetic variant. We want to make sure that you're in the right club, that you don't, and shouldn't be actually in a club down the road, that this is really the community for you. So with this, I won't go into too much detail, but if there are questions, we'll have time for questions and answers later. The thing that I wanted to impress upon you is that unless there's a number in this column here, there is only one person with that genetic variant within the DYRK1A community. So you'll see there are a couple where there are 2 people here, 2 people here, 3 people here, but otherwise almost everyone is unique. And as I said, to make sure you're represented, it's important that you're there representing yourself, because if you have one of these changes, it may not be exactly the same if someone else has a similar but different change. I'm going to point out very, very specifically, and I don't know if those in the audience will recognize it, but there are a few of you that have what we call missense changes or missense variations. The technical sort of terminology for this is this tells you the address, 283.310.467, but the exact address within the DYRK1A gene. And at those positions, I'm Wendy Chung. I'm a medical geneticist and pediatrician and very happy to be here for the DYRK1A conference. So we're doing it for the family groups.
I'm really sorry.
In a copy or uploaded a copy of your genetic test report. We do that as a method of now abstracting from that the exact genetic change that you have and making sure that it really is in DYRK1A, that it's the what we would call a disease-associated or condition-associated genetic variant. We want to make sure that you're in the right club, that you don't, and you shouldn't be actually in a club down the road, that this is really the community for you. So with this, I won't go into too much detail, but if there are questions, we'll have time for questions and answers later. The thing that I wanted to impress upon you is that unless there's a number in this column here, there is only one person with that genetic variant within the DYRK1A community. So you'll see there are a couple where there are 2 people here, 2 people here, 3 people here, but otherwise almost everyone is unique. And as I said, to make sure you're represented, it's important that you're there representing yourself, because if you have one of these changes, it may not be exactly the same if someone else has a similar but different change. I'm going to point out very, very specifically, and I don't know if those in the audience will recognize it, but there are a few of you that have what we call missense changes or missense variations. The technical sort of terminology for this is this tells you the address, 283.310.467, but the exact address within the DYRK1A gene. And at those positions, there's a single amino acid, a single building block in the protein that's swapped in, or a substitution for those. In particular, my hunch is that some of the researchers are going to be particularly interested in individuals who might have these changes, or at the very least, I won't necessarily say they're particularly interested, but that some of the individuals with these other types of changes won't be able to substitute or represent the individuals with these particular unique genetic variations. Within all of these, I'll also point out that for individuals in the community, they have 2 copies of the DYRK1A gene. One of them looks like everyone else, but it's one of the 2 copies that has the genetic difference that I'm showing you here. So one copy looks like it's doing most of the work. It's trying to pick up the slack. And then there's this one other copy of the gene with the genetic difference that I've listed here. I'll also say that for almost everyone in the community, these particular genetic differences are de novo, or they are new in the individual with DYRK1A. And I think probably most individuals listening know that already, but I just want to emphasize that it was nothing, if you're a parent, it's nothing you did or didn't do as a parent that caused this. This was literally something, there are these new or de novo genetic changes for anyone and everyone that has children. So no one's special, but what is special is that it happened to land within this DYRK1A gene. And that is what's unique and obviously what brings this community together today. So now let me get beyond the genetics 101 and let's dive down into what we understand about the individuals in the community. So this is a representation. I'll try on all the slides to orient you to what I'm showing you, but on the x-axis here is the age, and on the y-axis here is the number of individuals at that age group. So what I'm trying to show you here is the age of the 22 individuals that are represented in the data I'm going to show you. And you'll see that for the most part, they're less than the age of 10. We see the majority of individuals are still pre-adolescent. There are some older individuals, and this is important and extremely helpful. You'll see what I mean when I show you some of the data on the older folks. We do have teenagers, we even have young adults, but there are fewer in the adult category. That's not to say that there are not adults out there with DYRK1A. It simply means that they have not yet been identified as such, mostly because they haven't taken the genetic test that you or your family member has. So again, I'm not saying they're not out there. We just haven't at least welcomed them into our community. There are ways of accessing genetic testing for individuals, though, who are adults. So I would encourage you, if you know of any adults in the community who seem to have the features I'm going to talk about today in terms of epilepsy, neurodevelopmental issues, those are individuals, whether it's DYRK1A or one of these other related conditions, are helpful in terms of understanding long-term what to expect when individuals are in their 20s or 30s or 40s or 50s. And I think it's important for us to plan now for our little ones as we think and take a peek into the future and what might be helpful. So what are the things that we're seeing? I'll give you the good news at the very beginning, so in case I lose you at some point. The good news is that this appears to be a condition where children continue to make improvements over time. So in contrast, this is not a condition where children tend to degenerate or lose skills or regress. You may have heard some people use those terms. It is not, let me emphasize, not one of those types of conditions. But I do appreciate that it is a slower developmental growth. So I'll show you some of what I mean a little bit later. But again, forward progress, continuing to make forward progress, but at a slower rate. So most of what we see is related to, the way I think of it, is above the shoulders. In other words, it's in the brain, it's related to the brain and behavior, and to a certain extent, how the brain affects the way a few different parts of the body function. But mostly we're talking about an effect of DYRK1A in the brain. It is very, very common, almost universal, that individuals have problems with developmental delay or intellectual disability. And I'm clumping these together, but the point is that later in terms of walking and talking and learning new things in school. So not to say that these things don't come in, but they definitely take time, and they definitely need a lot of repetition, special education, special supports, but there is forward progress. Within these, one of the things that's most obvious early on are problems with speech. Now, I'll tell you, at least in my observation, I've had several patients with DYRK1A, their receptive language or understanding is not nearly as challenged as the literally getting the words out of the mouth. So I do, in my observations, have seen that individuals understand a lot, they can anticipate, they can follow instructions, but the actual mechanics of speaking, using your lips, tongue, throat, being able to get all of that coordination is challenging and takes time to come in. But do be patient. In the interim, as language is coming in, there are other ways of augmenting communication. So whether it's signs, picture cards, communication devices, lots of different things to work with your speech therapist and language pathologist on. But don't give up. And also be careful what you say because the kiddos are listening. One of the things that I mentioned earlier is autism, and autism or autistic features or autistic behaviors are seen in a significant fraction of individuals. It's certainly not everyone, but individuals do feel more comfortable with consistency. That's one of the things I've observed. They do like to help anticipating things, and sometimes they can get nervous or anxious if they can't. Because of that sort of level of comfort, they like things that are the same. They like some consistency. They like to be able to know what to expect. And for some, but in my opinion, really not the majority, there may be issues in terms of social engagement with others. But sometimes that's simply because of some of the other delays, at least initially. So problems in terms of walking or talking. It's hard to be able to engage and play with other kids, especially other kids your own age, if you're not able to keep up and do all of those things. So some of those things do get better over time. A little tiny few of them do have some other behavioral issues, problems with attention or attention deficit hyperactivity disorder, anxiety or obsessive sort of focusing on one thing. But again, a tiny fraction, and I'll show you some more data on that later. Some of the other ways that we see this manifest, and this is characteristic, is to have a smaller head size. That is a direct relationship to the gene and what the gene does in terms of development of the brain. And so this is something not to be afraid of. This is something to realize that that's part of that condition. There are problems with muscle tone, and you'll notice, and it may seem sort of counterintuitive because there's some children that have high muscle tone, others with low muscle tone, so hyper or hypotonia. We can see either, or in some cases, both in the same person. In some cases, it differs by part of the body. So as an example, I tend to see more low muscle tone, for instance, in the trunk, and sometimes higher muscle tone in the arms or the legs. And in some cases that may change over time, especially with physical therapy, with stretching exercises. We can help with some of the hypertonia. Building core strength can help with the hypotonia. So physical therapy can often be helpful in terms of those symptoms. Some individuals, in my experience, it's often been before DYRK1A was diagnosed, were diagnosed with cerebral palsy or CP. To me, fundamentally, it's not, when I think of cerebral palsy, it's oftentimes due to not having enough oxygen at birth, and DYRK1A is not due to that. So DYRK1A is not due to not having enough oxygen at birth. But I think what this implies to me is that individuals have some of that hypertonia or spasticity. And so I think that's really what we're seeing with the cerebral palsy. In terms of movement, I do think all of the kids at some point have problems in terms of motor coordination. So planning their movements, being really smooth and coordinated. Sometimes they can look a little clumsy, a little wobbly, and even sometimes have some accidents or some injuries because of that. But in general, there are some problems in terms of movement, and some may even have particular sort of facial tics or other things that are different behavioral issues that can come up. With this, one of the things that's most impactful, and we see in about 50% of the community, are seizures. And with this, really important, one of my recommendations, if you haven't already been evaluated for seizures, I do think it's important to have an electroencephalogram, an EEG. This is probably most relevant to the young children. Maybe if you just found out about your diagnosis, maybe you haven't seen a seizure yet. If you do have a young child with a diagnosis, I would recommend seeing a child neurologist and having them evaluate for seizures. The seizures can come in many different flavors, and any one person could even have more than one type of seizure. They may even change in terms of the type of seizures over the life course or with treatment. The point, though, that I want to make is that almost every seizure type is possible. And so it is really important to see a good child neurologist. They may not even have experience with DYRK1A. I'll warn you, it's still a rare condition and not every child neurologist is familiar with this. That's okay. You do want them, though, to know that this is associated with epilepsy and make sure they're doing a thorough evaluation. Sometimes that can involve an overnight EEG or electroencephalogram. And that gives you the ability when you're in the hospital to have the see in night and day, which includes during sleeping, and often to have a video camera on you so that if you see a movement, then you can timestamp it by pushing a button so that at the same time they can look at the picture of what the individual's doing, they can look at the brain waves and see when they see a particular movement, do they see a particular brain wave here, and make that correlation. That becomes important for certain types of seizures. Grand mal seizures or tonic-clonic seizures where there's moving and shaking and jerking of the whole body, that's kind of hard to miss. Most of us would recognize that. On the other hand, something like a petit mal or a very small seizure, meaning petite seizure, that might be missed because that can often look like daydreaming, kind of staring off into space or being kind of out of it. And it may not last very long, and maybe a minute even. And so something like that, it's sometimes hard to know for sure whether that's a seizure, but that's the advantage of doing one of those video EEGs. So again, because it's frequent, good to be able to have a professional evaluation with that. I'm going to switch now. So these are other parts of the body, and you might not have thought about the connection between the brain and the other part of the body, but in some cases, I think they are directly related. There are a couple things I will say with DYRK1A I don't think are directly related, and I'll point those out. So let me start by frequency, and this is on the x-axis, the percentage of individuals who had this particular set of symptoms, and on the y-axis, and I've grouped these by different parts of the body, but I'll try and explain what I mean by the different types of symptoms. So let me start by frequency. So I call this tummy trouble. So these are gastrointestinal problems. These are largely related to constipation in order of frequency. Constipation, number one, diarrhea and gastroesophageal reflux or heartburn. And some individuals, again, can have all three of those. Some of them can have on different days, different symptoms. But all of these can be really just making a child feel uncomfortable. And sometimes as a parent, you might not even know why they're having an off day. But when you start thinking back on it, it might be related to some of the tummy trouble. Unfortunately, I don't have a magic solution in terms of the constipation diarrhea, but what I will say based on a lot of experience with this is that there are solutions to this. Again, a good pediatric gastroenterologist can be very helpful. A general pediatrician whose experience can oftentimes be very helpful as well. The magic medicines are not magical in the sense that they're not specific to DYRK1A, but are oftentimes a combination of schedule, diet, activity, and then some medications when they're necessary to either move things along or keep things from coming back up the other way in the case of heartburn or reflux. So what do I mean by that? It's a little bit of trial and error, and I know that is challenging, and certainly even amongst the DYRK1A folks in the community, I'm sure you've shared experiences. There's no one right answer, but a combination of changing the amount of fiber in the diet, in my experience, changing the amount of dairy in the diet. For some people, it may be the gluten in their diet, but different things like that will help in terms of being regular and staying consistent and regular. I will say that once you figure out that sort of, diet that's really keeps someone feeling better, try and stay to that as much as you can. I'm not saying it has to be absolutely restricted and eating the same exact thing for every day of the week, but I think you will find that whether it's prune juice that seems to help or maybe not, or whether it's something that's for instance, a Miralax in terms of being able to clean things out. But the trial and error in terms of, like I said, medicines, stool softeners, keeping folks active. Again, the hypotonia tends to keep things stopped up, so keeping folks active and moving around, all of those things can be helpful. With this, like I said, One other thing, I guess I didn't say, but I'll say now, is that if you use antibiotics, so sometimes there's an ear infection or a kidney infection, but if there's antibiotics that are used, it can change the microbacteria in the intestine, and disruption of that can sometimes lead to issues. And so being able to repopulate the intestinal microbiome with probiotics, things that we'll get back to can sometimes be helpful too. Okay, next item. Eyes and vision. Eyes are the window into the brain. They literally are so important in terms of seeing the world around you, learning, getting an accurate sense of your environment, staying safe. Important to have the eyes working and both eyes working. And so some of you have noticed this in the past because, again, 77% of kiddos have had issues in terms of either a lazy eye or a crossed eye, or problems in terms of needing glasses and being able to see clearly. All of these things can be issues, but in most cases, they are correctable. And so incredibly important to know to be able to fix it when it needs fixing so that people can be safe, so that they can accurately see what's going on and so they can learn better. Pediatric ophthalmologists, especially those who care for children with special needs, can be very helpful. So again, especially if you're a parent of a young child, put that on your to-do list if you haven't done that already. Other than that, we do see some other things in terms of endocrine means gland problems. And the one that we see the most is in terms of growth, with children sometimes being skinnier and sometimes being a little bit shorter. So they come in a slightly smaller package. Sometimes that's related to the tummy trouble that I talked about before. If they're having trouble being able to tolerate certain types of food, sometimes they're not eating as much. I think I especially have seen this when the children are younger, and as they get older, both by our experience with figuring out the right diet that works for them, many of them, I'm not saying will completely normalize in terms of height, but tend to do better in terms of not being so skinny. One of the other things that we see that I don't think is necessarily related directly to the brain are heart issues. Most of these are structural congenital heart disease, so a hole in the heart or something in terms of the way the heart developed. This is something that the doctors can see by doing an echocardiogram or an ultrasound of the heart, and it's either there or not there. So if that's been done, you can cross that off your list. It's not going to come up in the future. If it's not there, it's not going to be there 5-20 years from now. Again, you can move on. On the other hand, if it is there, and obviously it's usually, this test is usually ordered by a pediatric cardiologist, they will dictate in terms of what the particular surveillance is, if you need to do anything special with dental work and taking antibiotics with tooth cleaning or trips to the dentist, or whether any particular procedures are needed. The other things that we're seeing, I would say, are relatively infrequent and oftentimes about the same frequency as the general population. The one exception I'll say is orthopedic or bone issues. Sometimes we're seeing that children might need braces or that they might have curvature of the spine or scoliosis, in particular as they get into adolescence with those growth spurts. Okay, so with this, I wanted to have a summary of the medications people are taking at the moment they did the survey, so you got a sense of how serious was this. To me, if something's serious enough to take a medication, that's kind of one thing, and I wanted you to see those numbers. So number one is about 1/3 of the community still is having challenges with seizures to the point of needing medication. The other point I wanted to make on the right here is that we survey parents to understand, is there a medication that seems to be most effective? And if it is, what is that? So that way some of the parents of younger children might be able to use that experience. I will say that this is, we had one medication which actually 6 people were taking for seizures that seemed to be more effective. And so I do think this is something helpful to know for those of you who may be showing this information to your child neurologist. There's another medication, which is cannabidiols or medical marijuana. A couple individuals taking that. This is something, just so that you know, it's relatively new in terms of being legal to prescribe this. And for some practitioners who've been in practice a long time, it's not something that they necessarily have experience with. So again, this is still sort of an emerging area for us to understand how helpful and for whom it's helpful, but I did want you to see the data. Otherwise, a lot of what we were seeing are mostly, again, the tummy trouble in terms of medications for intestinal problems. And I'll come back to it later, but a few people, very small, but a few people in terms of behaviors needing to have some treatments for that. Okay, so now let me dive into the brain and behavior and development. So what we've done here is looked at all the individuals who filled out these surveys, in this case about 20 individuals. This survey is a standardized instrument called the Vineland Adaptive Behavioral Scale. Each dot represents a different person, and I'm showing you the age at evaluation on the x-axis here, so 2, 3, 4, 5 up to 18 and above. And then this is on the y-axis here, sort of what a comparable developmental age is. So you could have someone that might be in chronological or actual age about 2 years old, but in a developmental age, they're acting or working at the level of a 1-year-old. That's the way to read this chart. The other way that we put some things in here for you to get a concrete sort of sense of what is a child able to do at different stages is we put in some examples, and that'll be true of the next few slides I'll show you. So being able to talk in terms of a single word, so first words, I should say, not talk, but first words. After that, asking a simple question, telling a story. And the reason we did it like this is, again, it gives you a sense of how much language are they able to speak in complete sentences. And so you get a sense of this over time. Now, as I said, some of the limitations are we've got a lot of the younger children, we've got a few of the teenagers here. We do have a few missing sort of ages in the middle here, but so we made it an extrapolation here, made some guesses about what the middle ages might be. So the good news to me, and you'll see this on all the graphs, nice forward progress, improvements over time in terms of what people are able to do. And in terms of gaining skills from a verbal point of view, certainly improving in terms of that over time. This next slide, set up the same way, is now looking at personal care skills. So I always think about, well, you know, how independent can someone be? How much can they take care of themselves at home? How much can they do on their own? And so some examples of that are, for instance, feeding finger foods, being able to then use utensils in terms of eating, or being able to help getting dressed, you know, different things. And again, nice forward progress over time. Slow, admittedly, but nice forward progress in terms of additional skills that are made. When we think about social development, so again, thinking about interacting with others, being able to, whether it's playing or speaking or engaging with others, and again, nice progress over time. Some of this is in terms of imitating gestures. So, you know, if you're playing patty cake or other games like that, being able to help out, work with someone to get something done. So whether it might be something like putting things on the table for dinner or being able to help out with simple things around the home, making nice progress here. And eventually being able to interact and have friends and playing with friends. Maybe sometimes they're older or younger children chronologically, but still playing with others. In addition to that are things that have to do with gross motor, so movement, moving your body, moving it in space and being coordinated. And this takes time, but I do want to make the point that walking independently, definitely possible. More complex movements in terms of hopping, skipping, jumping, running, things like that coming in over time, but more slowly. Then obviously safety is always an issue as we're thinking about how to supervise the children. And for that reason, many of the children will have paras in school, individuals to help them in terms of that getting around, to get around safely. Okay, so just a couple more things. So there's another survey that we gave you, something called the Child Behavior Checklist. So this is screening children for other types of behavioral conditions. And I'm breaking this down into the younger and the older children. So the younger children first, age less than 5. And the good news here is that there are really not any concerns. So I'm showing you the threshold, all the different measures that we look at. So whether it's sadness, anxiety, attention issues, we're all for the little ones in a range that's not concerning. So that's really good news. In the older age range, kiddos that are age 6 to 18, again, same categories, and still in a good way, not in things in age in ranges that are concerning. Everything is not a concern in our kiddos. So that's really good. We don't seem to be having those types of issues. So when we look overall, though, we do hear that there are certain things that seem to be a little bit more common. Again, with the little ones, we see things like they're a little squirmy worm. They, you know, sometimes go from one thing to another. There's sometimes putting things in their mouths that they probably shouldn't be. So we do see that about the younger kiddos. And then when we look at the ones that are slightly older, again, some issues in terms of attention. As you may have seen, that it maybe not ADHD officially, but problems where they can get easily distracted, where they may have some repetitive behaviors, do things again, some focusing on certain things, some obsessions, and maybe some problems with impulse control. And that's what we're seeing from a behavioral point of view. Now, the last thing I'll close up with is that we've taken some individuals rather, have answered the same surveys, the same instruments of the child behavior checklist over time. And so we call these spaghetti plots. So these are like the spaghetti noodles. Each one of these in a different color is a different person. And you can see, again, on the x-axis here, their ages, and on the y-axis, the level of concern, similar to what I showed you before. So the good news from my point of view is, again, if you think about those in a level of concern, either significant concern up here, mild concern, or no concern, majority of individuals are of no concern, and most people are basically staying about the same. Some people getting better over time, even, I think, as we're able to understand how to best work with them and support them. In addition, and that was what we call internalizing behaviors, or behaviors that you might not see outwardly expressed, for some of the more outwardly obvious behaviors in terms of tantrums or fits or explosions. Again, for the most part, individuals not having those issues being an issue of not having concerns, just a couple individuals who are in those levels of significant concerns. And as I said, there are some individuals actually taking medication in some of those cases. So just to wrap things up, overall, again, good news in the sense that things seem stable. Children are improving over time, getting better, gaining skills over time, but a couple points that do warrant being careful about, making sure that we don't ignore them. Issues related to seizures, really important if they're there, see them, diagnose them, get them treated, get them under control so that the children can be able to be safe and continue learning and making that forward progress. Vision, make sure that vision is taken care of, and be patient. So those tummy troubles, those weight issues will get better over time. Do be patient with that. And as I said, overall, I know it's challenging. I know it takes patience in terms of dealing with these things, but I am, as I said, optimistic that things are getting better over time. So I thank you for your attention for that. And we're going to have some time for questions.
Okay. So, oh, sorry, who's starting? I didn't want to talk over anybody. So that was a great presentation. I know it was a lot to kind of to digest all at once, but we have Dr. Cora Taylor here, and she's going to answer any questions. So right now, everybody's mics are muted. So if we want, I'm going to read off one of the questions that we have here from Sarah. It says, how are variants classified as pathogenic?
That's a great question. So when you got genetic testing initially, before you even joined Simons Searchlight, because potentially your child had a developmental delay or other reason, the lab that did your testing did make did identify whether or not they felt like the variant was pathogenic or likely pathogenic based on the information that we had. A lot of that is through whether or not we see whether we've seen that variant before or whether we know what that variant does, such as we know that it disables the gene from working, might push us in the direction of saying that we think that this is a pathogenic variant. In addition, when you enrolled in Simons Searchlight, we also did our own independent review of your variant and made our own designation as well as to whether or not we felt that your variant was pathogenic or likely pathogenic. In addition, we do that every year. So if there's anybody on the call who potentially, they have a variant of uncertain significance, we do review those independently every year to try to see if any might be likely pathogenic or pathogenic based on the information that we have about the gene and how it works, if we've seen that specific change or variant before, and what we know about how that change affects the gene. Oh, Adrian, I'm sorry, I can't hear you. You're on mute.
Sorry, I always forget to unmute myself. Sorry about that, guys. So it says, we have a question from Katie. It says, is there a best guess onto what overall level of functioning might be? For example, functioning like a 10 or 8 to 10-year-old.
That's a great question as well, because as parents, I think we always want to be able to understand what to expect for our child. It tends to be really difficult to make specific guesses, and even as clinicians, when I see a child only one time, even if I know a genetic condition, in most cases I'm a fairly poor predictor about where that child is going to be in the long term, because the best guess about where children are going is not really where they start, but their trajectory. So how do they respond to therapies and to interventions and to treatment? What we do know, and that I think Dr. Chung did a really good job of explaining, was that we do expect these children to make really nice progress over time. And really the best judge of where your child is going to be is the trajectory that they're on. So if you're working with a developmental pediatrician or a school psychologist who is seeing your child kind of on a regular basis and potentially doing some updated developmental evaluation, you can kind of track your child's progress over time and build that picture. So when they were first evaluated at, say, age 2, where did they start? And then when they're evaluated at age 4 and age 6, how much progress have they made? Because you can expect your child to kind of stay on that trajectory. And we have the most impact on children's trajectory when we start interventions early. So really before the age of 7 in particular, we have a lot of power over helping change how our child is developing. So working with a provider who can track your child's development over time is really important. And Adrian, there were a couple of questions, and I jotted them down that came in through the chat, and I can answer those really quickly if that's okay, and then I'll turn it back over to you. So one question was about the heart, and just clarifying what the heart conditions are. So what Dr. Chung was talking about are what we call congenital anomalies. So it's something that is structurally wrong with the heart, like potentially a hole, and your child is born with it. So this is about close to half, but less than half of children with DYRK1A do have a structural problem with their heart. And one of the take-home points there is if you have had an echo, so they've looked for problems with the heart through an echo exam, looking at the heart itself structurally. If that has been negative and have not found any structural problems, you don't need to worry about checking it later. So it's something that you can check once. Just make sure that your child doesn't have any structural problems. And then, like Dr. Chung said, you can cross it off your list and move on. We don't expect that children with DYRK1A will have any additional structural problems other than ones that they may have been born with. Another question was about the number of individuals that have been registered from last year to this year. So last year, our presentation included 19 people. This year, it includes 22, but we did have a couple other people register even in the time that we pulled the data. So we're actually now up to 24, but we do have a lot of individuals registered, but it's just a matter of kind of getting through the process. So I would definitely encourage you, if you've registered for Simons Searchlight, but you're not sure where you are in the process, you don't know if you've had a phone call or not, you're not sure if we have your genetic lab report, please reach out to us. Our staff is more than happy to help you try to figure out where you are, what you need to do next in order to keep moving forward with your participation in Simons Searchlight. And I think those are all. So Adrian, I think those are all the questions that I had jotted down. If you want to give me another.
Okay, great. The question you just answered, there's one that's kind of similar to that, so I'm not sure if it's the same as the one you received in the chat. But it says, have there been, sorry, I was hearing a little bit of a lag. I was making sure someone wasn't trying to talk. It says, has there been many new families added to this study? My impression is that the number hasn't changed much over the past 2 years.
Yeah, so yeah, that's exactly. So when we look at the number of people, we look at people based on kind of where they're at in the process. And in order to have your data represented in this presentation, you had to have had your phone call with the genetic counselor who talked a little bit about your child's medical history. So we have many more people who have registered in the last year than who have gotten all the way through the process of getting to that medical history interview and completing surveys and having their their data represented in this presentation. So definitely, like I mentioned, if you have registered but you haven't, but you're interested and you have not gotten through the whole process, let us know. Misha put the email in the chat, coordinator@simonssearchlight.org. So if you have questions, again, send that to us and we can let you know where you are in the process at any point in time and help you through wherever, whatever questions you have. Adrian, I think you're on mute again.
So I'm so sorry. My daughter's playing in the background. I guess I might just leave it unmuted unless if she starts getting loud or something. But it says seizures are a huge problem for my son Quentin. Are there any neurologists that work with DYRK1A individuals and understand their mutation?
That's a great question, and it's one thing that I think is part of Simons Searchlight we want to learn. But currently, we don't understand a whole lot about how certain medications, or most neurologists have met, because DYRK1A is so rare. Many neurologists have only met one or only a handful of children with DYRK1A, and there aren't any specific medication guidelines currently about how to treat children with DYRK1A differently. So I would find a pediatric neurologist who's willing to really partner with you and lay out a lot of the options and really do a nice kind of progressive approach where you're going to try a lot of different options for your child. But partnering with a pediatric neurologist is the most important thing. And finding a pediatric neurologist who specializes in DYRK1A, we can definitely take a look and see if there's anyone in particular that we would recommend. But because of the how rare DYRK1A is, that is a difficult thing to find currently.
Great. So we have another question. It says, have you tracked reports of the cortical vision impairment? I believe I'm pronouncing that correctly. The CVI in our community. My son is 20. He was diagnosed with this. He was diagnosed this year with it. It may be of interest since CVI and autism have some shared behaviors.
Yes, I'm just taking a quick look at, so we definitely have the majority of children with DYRK1A having some kind of vision impairment. Currently, we don't have anyone reported specifically with cortical visual impairment under kind of this general eye and vision problems. But as Dr. Chung mentioned, certainly and very specifically, an eye exam is really, really an important part of management for children with DYRK1A, and certainly reasonable to evaluate for cortical visual impairment.
Okay, and I think you kind of addressed this question a little bit ago, but I'll go ahead and answer it since it's here in our questions to make sure if there's anything that needs to be clarified. It says, I missed, what do we need to be aware of the heart? Someone replied, check for a heart murmur, I think. And you had mentioned that well, I'll let you go ahead and address that.
Yeah, so I think there's two really important points. One is that most children with DYRK1A that we know of do not have a difference with their heart, and for the most, and in general, children with DYRK1A, if they have a problem with their heart, it's what we call a structural problem, meaning that there's something wrong with the way that the heart formed in the womb. So it's something that the child is born with, and it's important to evaluate for that, and especially if there is a heart murmur in particular, your child should have a medical exam that's called an echo, and that just has an ability to look at the heart and to see if there's any differences, like potentially there's a hole in the heart that might be causing the murmur and if that needs to be repaired. If your child has had an echo and it was normal, there's no reason to expect that they are at higher risk for other heart problems. So if they did not have a hole in the heart when they were born, we would not expect them to develop it later. So if your child has had an echo, you don't need to necessarily continue to follow with a cardiologist unless something else comes up. We wouldn't expect your child to be at increased risk because these are conditions that typically your child is born with.
Okay, and we have one last question that came in. It says, any recommendations when you have a transition from a pediatric to adult neurologist?
That's another really good question. I would start planning for that very early. So as early as possible. So, and that can start with just starting to talk to your pediatric neurologist about how long they feel comfortable seeing patients if they're no longer pediatric. So sometimes if you're working with a pediatric neurologist who has a lot of experience in developmental disabilities, and certainly many developmental pediatricians will continue to see children until they're early adulthood before they try to transition them into adult care. And then reaching out to adult pediatric providers adult providers while your child is still in pediatrics to try to make that transition. So that can be a really tough one. But asking for recommendations from your current neurologist, trying to reach out before the transition even happens, best understanding how long your provider will see your child, until what age. So those would be my primary recommendations.
Okay, great. We have a couple more minutes. If there's anybody that wants to submit a question through our question and answer format, or if they would like to unmute, they're welcome to in the last couple minutes. We'll go ahead and wait for that. If not, then I'll let Anna take take over and she'll give us our closing comments.
There was a few questions coming in through the chat. Sorry, hi, this is Misha. I was just keeping track of the different places that questions were coming in. There's the question that says, what information should I bring to a new neurologist to explain DYRK1A? My son is an adult, 20 years old. We are transitioning to an adult neurologist. So far, we've been disappointed with the lack of information and misinformation regarding our son.
So if you want to bring information to any medical provider about a child with DYRK1A, the place that I would start is a resource called Gene Reviews. Most clinicians who work with children with genetic conditions are fairly familiar with Gene Reviews, but and I'm just taking a look too, it looks like it was just recently updated. So Dr. Eichler and others updated this in March of 2021. And what Gene Reviews does is it takes all the information that's been published about a single genetic condition and distills it into one document and focuses on medical and developmental issues that your child might be experiencing. So that's a really great place to start, and it's targeted for clinicians who don't know as much about genetic conditions. It's freely accessible. So if you went to Google right now and you Googled DYRK1A syndrome Gene Reviews, you would be able to pull it up as a parent and print it and physically take it to your doctor or your provider, or you could tell them to look it up. But it's a free resource that's open and available for families and for their providers.
I also just noted that Simons Searchlight, Dr. Wendy Chung is preparing a publication on the information within Simons Searchlight. So that this will be published as well, and this will be highly updated and available to review and bring to providers. So we hope that will be helpful as well.
Misha, do you want me to cover the rest of the questions? Because it looks like there's maybe like one or two more.
Sure, go right ahead. Thank you so much.
Yeah, you're welcome, no problem. So it says that, can we develop a network of providers that work with our children?
That's a good question. I think that's going to be something that you guys can discuss potentially as a family group about identifying providers that you've worked with and being able to recommend those providers to others. Certainly, when you find a provider that has been open or has met potentially more than one child with DYRK1A, they can become sort of your expert in DYRK1A. But yes, I think that's a communication largely between a lot of the families about who we worked with, who seems to be very responsive and open to learning about DYRK1A, sort of above and beyond just the general neurological issues that your children experience. But communication within the family group, I think, is critical to building that network.
Okay, great. I think that's it. And then I'll go ahead and let Anna do her last couple announcements, and then we can move to our next session shortly after.
Great. Thank you very much.
So thank you. I hope you all enjoyed the session as much as I did. So as you know, the session is being recorded and going to post in our YouTube channel. And what's next is we have the DYRK1A for DYRK1A at 21-day challenge. You probably saw some of the posts on Facebook. If you didn't yet, go check it out. Some of our posts on Facebook and Instagram. Join us for this challenge. invite your friends. Let's make that bigger than it was last year. It's our second DYRK1A for DYRK1A. And the challenge is going to be from August 1st tomorrow to August 21st. And we are finishing the challenge exactly in our awareness day. So thank you. I guess we have a couple minutes break and we're going to start our next session. Thank you.